Good evening, one and all. This is Dr. Shruti Sharma on the behalf of PAN, Physician Association for Nutrition. I welcome you all and I'll thank you all. Before we start, we should thank our lead ambassador, Dr. Spurti Kalyan Sundaram, who managed to do this 22nd CME here. So I would like to invite you, ma'am, to kick off this CME from here. Before that, I would like to introduce you. As most of you must be aware about her already, but still I would like to introduce Dr. Spurti Arun Kalyan Sundaram is an American board certified internal medicine physician with 16 years of extensive experience. She completed her MBBS at the prestigious Madras Medical College, Chennai, and her internal medicine training at Gizinger Medical Center. Am I right? Okay, USA. She also holds a degree in medical informatics from Oregon Health and Science University. Dr. Spurti has worked at renowned institutions, including Cleveland Clinic and Virginia Mason Medical Center, where she played key roles in quality improvement and medical informatics. Currently, she is Managing Director of Pasteur Healthcare and Promit Hospital in Chennai. Her expertise spans clinical practice, lifestyle medicine, and healthcare technology, making her distinguished leader in the field. Welcome, Dr. Spurti.
A very good evening to one and all. A warm, warm welcome to all of you here. Thank you so much for taking the time, especially this particular meeting as we inaugurate the first PAN Chennai chapter. And this is our very first conference. So PAN India has done numerous CMEs all over, and their objective is to talk about nutrition, evidence-based nutrition, to physicians like us and allied health professionals. We would like to start off today. We've got a little bit of a delay with our medical director. Her flight got a little delayed, so we're going to start off with our first speaker, Dr. Arun Kalyansundaram. I'd like to take a few moments to introduce Dr. Arun Kalyansundaram. Dr. Arun Kalyansundaram is a distinguished interventional cardiologist specializing in chronic total occlusions and complex percutaneous coronary interventions. He is the Asia Pacific CTO Club Director and Chief of Cardiology at Promit Hospital, Chennai. He is also has been the director of CTO PCI and interventional cardiologist at Marshfield Clinic, Wisconsin, USA. He has held key positions at Fortis Escorts Heart Institute, New Delhi, and the Swedish Medical Center in Seattle. He has also served as a chief of cardiovascular medicine and cardiac catheterization lab director at Highland Medical Center, Washington. Dr. Kalyansundaram completed fellowships in interventional cardiology and research at Cleveland Clinic and Geisinger Medical Center. He's a clinical assistant professor at the University of Washington and a proctor for CTOs and complex PCI globally. Board certified in internal medicine, cardiovascular disease, and interventional cardiology, he has authored numerous publications, presented at international conferences, and pioneered the K14 technique for CTOs. Recognized for his contributions to cardiology, he holds advisory roles with several medical organizations and has received multiple awards for his academic excellence. May I invite Dr. Arun to the stage, please?
Good evening, everyone. Thanks, Dr. Spurti, for the kind introduction. So I'd like to thank you all for first taking time off on a Saturday evening to get here. So I'll try and make it as interactive as possible. So the first topic really that we're going to talk about as we inaugurate the PAN Chennai chapter, PAN India Chennai chapter, is straight from the heart. Let's get some facts straight. So I have a disclaimer. So this is what I do for work. And from a business standpoint, I'm actually speaking against my best interest, because if there were no coronary artery disease, I wouldn't have a job. So I always tell people, your job is to put me out of a job, all right? So the next 15 minutes, we'll talk about why this matters. I see a lot of young, bright faces, so I'll also take a few minutes to talk about what is heart disease and what's a heart attack. I'll look at some of the data. And finally, we'll just see how to operationalize all this. So, typically, if you look at our standard Indian diet, essentially we're predominantly carb-based, take some protein and a good generous amount of fat. And that's not what is going to be served here today, but typically this is what we get in I would say when you have a good lunch or dinner, etc., you will see a lot of these items. And what's the problem with this? You have a lot more sugar than you need. A lot of these are fried and, like, they're pretty greasy, and you have other refined carbs. Also, increasingly, there's westernization of the diet, which unfortunately essentially translates into more animal products. And again, just to, not to kind of quote unquote body shame, etc., but something that we have noticed, I would say, in the last two decades, really. So is that we are increasingly seeing what we call morbid obesity in our part of the world. When I grew up in India, it was very, very uncommon to see, very, very obese people, and also childhood obesity. I think as healthcare providers, you'll all appreciate the fact that you're probably seeing it way more than you should. Interestingly, it's not just about the exterior. A lot of people, almost 50% of those that have a quote-unquote normal BMI are metabolically unhealthy. And this really is sad, because a lot of these people are living under the illusion, oh, well, I just go to my cardiologist, I get an ECG, and I've done my echo and a treadmill test, I'm pretty good. But essentially, and even if they're watching their weight, they kind of think it's all good. But the reality is the inside is a very different story. And just to kind of, again, emphasize this point, we keep seeing this news all the time. And of course, media likes all this stuff. It's like, hey, is going to the gym is what is killing you? Is it just because, whatever is the latest fad, and to just pick up something and say, is this the reason why people are dying? The reality is, it's actually back to the basics. So, and we'll kind of drive home this point in the next several minutes. If you look at it, we have a lot of cardiac disease in our world, in our part of the world, and significant number of deaths. It's the #1 killer in America, India, and globally, okay? And this is just cardiac disease per se. Cardiac plus stroke really puts us right at the top, followed by cancer. And the numbers are getting worse. Interestingly, this is something that I saw from several years ago. We just want quick fixes. We don't really want solutions or do a deep dive into what is causing all this. FDA apparently, this is way back, I think more than almost 20 years ago, for obese dogs, it's okay to take statins, which is very interesting. And we hold the distinct, we should be proud, and I mean this in a not true way, that we are the world's largest cardiac population. We are also the diabetic capital of the world. And now we're going to just switch gears. So if I haven't scared you enough, we'll just now talk about what is heart disease, what is heart attack, and why should you care. Heart disease is just basically any kind of disease that affects the heart. So it could be coronary artery disease, which is essentially blockages in the plumbing supply of the heart. You have rhythm disturbances, which are, again, the basket term is arrhythmia. And of course, many times, coronary artery disease and other kinds of disease also can lead to what we call heart failure. This can be because the pump doesn't pump well or it doesn't relax well. And specifically focusing on coronary artery disease, your vessels are supposed to be clean. I don't know if you can see the pointer, but okay. The #2 is how it is supposed to be, but oftentimes as we get older, we start forming plaques, and these are not benign. Interestingly, people always think, okay, heart disease is going to affect the elderly, right? I don't have to worry about it in my 20s and 30s. Breaking news, two things. There was a Korean autopsy study done after the Korean War. People as young as in their late teens to early 20s actually start getting plaques early on. So the atherosclerotic plaques start forming early on. And #2, increasingly, especially in India, etc., we see heart attacks and coronary artery disease in patients in their 20s and 30s. It always bothers me when I do procedures on patients that are younger than myself, and I'm seeing that a lot. Again, coronary artery disease can result in no symptoms. It can result in angina, which is exertional symptoms. Basically, when they climb up a flight of stairs, walk fast, etc., they have any kind of exertional symptoms. This could include chest pain, shortness of breath, fatigue. It gets better as they stop, many times attributed to just normal aging. Or it could be dramatic and present as a heart attack, where essentially a plaque ruptures like a volcano, and a blood clot basically blocks the vessel. And so here, this is kind of a busy slide, but really what I want you to take from this is that there are a couple of processes that actually happen that lead to atherosclerosis worsening. Number one is inflammation. On the right side of the slide, you see NF-kappa B and TLR, etc., interleukins, TNF-alpha, etc. It's a lot of pro-inflammation that happens, and atherosclerosis is increasingly recognized, actually I would say over the last 2 decades, thank you, as more and more of as a disease of inflammation. Further, of course, the usual suspects, your cholesterol matters, LDL ApoB matters, how healthy your vascular endothelium, that is the lining of the blood vessels, are, that matters, etc. So it's a combination of a lot of things in play, and this results in, it's like a plaque, small rupture, a little bit worsening, sometimes it's a little bit slower, etc. And then one fine day it could just suddenly rupture and lead to a heart attack. Again, in the interest of time, etc., all I want you to pay attention to is this part. Reminds you of a volcano, doesn't it? Just like a nice mountain here, just something exploding. Really, this is what happens inside the body, and the platelets that are supposed to protect us when we bleed kind of act against us, which is why in a heart attack, doctors oftentimes will give you very powerful blood thinners and antiplatelets. So, all right, this is all doom and gloom, like, why are we talking about diets and what is the whole idea of all of you guys being here? Plant-based diets, interestingly, do a lot of things to us. Decreases HOMA-IR, decreases your bad cholesterol, both your non-HDL and your LDL, reduces oxidative stress, and also improves how the lining is, the vascular dysfunction is reduced by plant-based diets. And it also has a favorable effect on a lot of your risk factors for atherosclerosis, basically diabetes, hypertension, hyperlipidemia, and combined the metabolic syndrome. I am not getting into this, but I'm happy to talk about this offline later if people have questions. Again, just to do a little bit of a deep dive, with diabetes, reduces microvascular complications. With your hypertension, it reduces the oxidative stress, etc., and reduces your risk of high cholesterol by decreasing cholesterol absorption and by improving your plasma lipid profile. And now let's look at the data. This is all good. The theory sounds fantastic. You don't really believe me. It's like, I'd rather, it's like, how can diet really matter? Because we've always been told that eat what you want, do what you want, just work out, you're young and healthy, and life should take care of itself. Now, there's a lot of stuff that's not great with animal-based products, and in general, right? They do contain a good amount of fat, saturated fat in particular, and cholesterol in fairly high concentrations. They also have animal protein and iron, which can create an environment which increases your heart disease risk, and reducing the consumption of other food components. So if you're eating a lot of this, you're not eating a lot of healthy stuff that you should be eating, which can be protective against heart disease. And again, just to emphasize, I would love to say it's all about the heart and nothing else really matters, but obviously there are lots of other specialists here, and jokes aside, diet affects a lot of organs, okay? It can affect your risk of stroke, risk of cancer, diabetes, hypertension, being obese, your knee pains, joints, etc., osteoporosis, whatnot. And obviously, so eating healthy will reduce your risk of all those bad things that I told you about. Now, just a few important things, right? One, I would like you to kind of focus on this thing called TMAO, trimethylamine N-oxide. This essentially is, this can be measured in the urine and in your plasma, and kind of correlates with cardiovascular disease risk. And kind of going along with the theme, plant-based diets generally decrease your TMAO, animal-based diets increase your TMAO, okay? Lots and lots of studies have been published about the correlation of diet and cardiovascular outcomes. To just state a few, you have the AHS2, the ARIC, the EPIC Oxford trial, and the broad trial. Essentially, just to kind of sum it up, the message is more plant-based reduces your risk of coronary artery disease and a lot of the risk factors. Now, there's all this confusion about eggs. In general, egg is very versatile, right? We all love our eggs and, you know, the various forms in which you can have it, etc. And there's a lot of confusion about, there's one study that comes out saying, oh, eggs are great. Don't worry about it. You can have all the eggs that you want. And some say, okay, in moderation is fine. And some say, okay, eggs have cholesterol. But then there's more data that we talk about saying dietary cholesterol doesn't really matter. It's all made in the liver. So there's a lot of confusion. If I may sum it up, in general, there is a linear correlation between high egg consumption and the total plasma cholesterol and LDL cholesterol, which is the bad cholesterol, okay? Now, also, when you look at diabetics and people with pre-existing cardiac conditions, I think egg consumption puts you at a slightly higher risk of adverse cardiovascular outcomes than if you don't. And interestingly, infrequent egg consumption does not seem to influence the risk of coronary artery disease. That was a study that was done in male doctors, but I think it can be extrapolated to the general population. And if you eat a lot, it does correlate with mortality. Mortality, as we know, is death, and that's pretty bad. Fish. I want to just talk about this very briefly. Overall, fish has omega-3 acids. There's a lot of good, healthy stuff that comes out of fish. However, I think we have kind of messed up our own food source. If you think about it, there are just two things that I wish to kind of draw your attention to. Number one is microplastics, nanoplastics. We always think about, we don't really care about the environment. Oh, that's for all those guys that are the tree huggers. Hey, we like our glass. I mean, we like our plastics. It's very useful, etc., etc. Just last year, there was this fantastic study that was published. They basically studied, carotid endarterectomy is where when you have blockages in the blood vessel, the carotids, that's the blood vessel supply to the brain. And if it exceeds a particular level, you can do surgery and essentially take it out. So what these guys very cleverly did was to study the prevalence of MNPs, microplastics and nanoplastics, in these samples. And they basically compared it with those that didn't have it. And what they found was, if you have MNPs in your carotid plaque, number one, the first inference is that it actually accumulates in our bodies too, right? What is bad for the environment is bad for, other animals. It's also bad for us because we also live in this world. And essentially, these patients that have MNPs are at a much higher risk in follow-up of adverse cardiovascular outcomes. This was very, very interesting. The other, and stating the obvious here, is that we all have studied back in med school, bioconcentration, biomagnification. In fact, my daughter and I were just talking about this on the way to the, to this talk here. You should be super careful because, unfortunately, fish tend to, what is not good for the fish is also not good for us. So there are certain kinds of fish that carry specific warnings. Hey, if you're pregnant, don't eat it. If you're of a child, if you're a childbearing age, don't do it. If you're a growing child, don't do it. So in general, just food for thought. If it's not good for the vulnerable population, perhaps it is not good for the general population. Now, the other argument that's often made is like, well, it's all good, but come on, I got to live a life. I can't survive on eating only plants, and also is eating only plants healthy? Now, this is, again, from almost 2 decades ago. And what was said, and I think what still holds true, is, an appropriately planned vegetarian, including a vegan diet, can be nutritionally adequate. I would say the one caveat being watch your vitamin B12 level, and that is something that you might want to take supplements of. So again, going along with this theme, tons of studies have basically shown that a plant-based diet reduces your cardiovascular outcomes, reduces a lot of the risk factors for cardiac disease. A meta-analysis is where basically they pool studies. Okay, this could be case-control trials, this could be randomized trials, etc. Or sometimes they just combine a lot of these in order to get enough power in that particular study. They basically showed that having a plant-based diet reduces your risk of heart disease by almost 25%, the relative risk being 0.75. Just a few other trials that I wish to mention. One was from the plant-based portfolio dietary study. This is they basically looked at 3 large prospective cohort trials and showed that the risk of coronary artery disease was reduced by 14%, the relative risk being 0.86 there. And this is from the Women's Health Initiative. I don't know how many of you are familiar with this, but this was this uber large prospective registry trial that essentially followed up these nurses for years and years together. So they basically saw them when they were young, in their late 20s, and they just kind of followed up. And so I was like, what's going on? And they did a study on everything, pretty much their lifestyle, exercise, what they eat, and all this good stuff. And what they did find, once again, was those that were adherent to the portfolio trial, diet, essentially had lower risk of total cardiovascular death, coronary artery disease. If it's on this side, right, it does not meet statistical significance. So stroke, no major difference. Heart failure, yes. So CVD, coronary artery disease, and heart failure, those patients tended to do better. Now, guidelines went back and forth. The last set of guidelines that came out essentially said, the sum total would be that a plant-based diet rather than animal-based protein is beneficial. Keep your cholesterol overall, daily intake to less than 200. And they also did say, I think they finally kind of thought, okay, we're going to put this matter to rest. Dietary cholesterol modestly does correlate with your blood cholesterol levels and your LDL cholesterol levels. Agreed that predominantly it's made in the body, but we can't always control this because there are, each one of us is different genetically, right? You can't control what your parents made you into, but you can control what you put into your mouth. Really, I think that's what the bottom line is. And, okay, I think I'm boring you guys with studies, but this is one of the best studies that came out. The problem with looking at dietary habits and outcomes is that there are too many confounding factors. Even if the trialists are really clever and they try to say, okay, we're going to do a questionnaire, we're going to validate what you're eating, we're going to do this and that, it's still very hard. I might say, okay, I eat eggs, but then maybe I'm eating it with bacon. Maybe I eat my eggs in a very healthy manner. So it's really, really hard to tease out very subtle differences in any observational trial in general. So this was a fantastic and a very clever trial, in my opinion, where they basically took twins, identical twins, and so you're straight away eliminating, for the most part, the genetic variation amongst the siblings, right? And essentially what they wanted to do was an 8-week intervention of, mind this, a healthy omnivorous diet. So this was not one of the standard American diet or the SAD diet, as people call it, and I don't think the Indian standard diet is any better, but this was actually a healthy, planned by a nutritionist, omnivorous diet. And they pitted this against a healthy plant-based diet. And what they wanted to see was, does this actually have, in a span of 8 weeks, any difference in cholesterol levels? So this was the study design for those that are interested. So they basically had, they randomized 44, one dropped out. So essentially they came out with 21 on each arm for the final analysis. And what they found was TMAO tended towards significance, but didn't reach significance. But the study met its primary endpoint, which is LDL. Study after study, we have large epidemiological studies which have shown that LDL levels correlate with adverse cardiovascular outcomes. This is one of the biggest rationales for statins, and for these days we are shooting for targets lower and lower. They showed that within a span of 8 weeks, amongst identical twins, that it is possible to reduce your LDL with a plant-based intervention diet compared to a healthy omnivorous diet. So I thought this was pretty cool. Again, this was also validated in a meta-analysis, essentially just showed that plant-based diets can result in a much more favorable lipid profile. So, long story short, diet matters, okay? I think what we call as the modern diet, all the greasy, fried stuff, there's another term I keep hearing these days, I'm a foodie. I'd never heard that, in the 80s and 90s, but people say, all right, I just like to eat. I'm like, sure, but just realize the true price that you pay for what you put into your mouth. And there's lots more data. Okay, I'm happy to, again, discuss this with people if they're interested in, et cetera, et cetera. I only put this on not because this happens in every patient, but this is actually an angiogram from Dr. Calvin Lesselstein. He actually kind of inspired me to get on this whole journey when I was at the Cleveland Clinic. He is not a cardiologist, contrary to popular belief. He kind of starred in as one of the lead characters in Forks Over Knives. Huge plant-based proponent. Also a very inspiring guy. He was part of the 1956 Olympic gold medal team in the US, so obviously a very driven individual. Got interested in CAD, and I think I was one of the few cardiologists that actually would talk to him because he was considered a pariah even in the Cleveland Clinic because he was like, diet matters, and no one really wants to talk about it. So this was a patient that actually had reversal of atherosclerosis. Again, does not mean every patient is going to have this. I want to emphasize that. So it's not like, hey, can I just do clean eating and stop all my medications? Please don't do that. That's not what we are recommending. The only other thing that has been proven to actually cause plaque regression is high-dose statins. And I'm kind of speaking against myself right now. But I tell this to people all the time, so there's no shame in it. I want people to also realize that stenting, bypass surgery, ECP, chelation therapy, whatever else is being touted as the next cure, does not cure heart disease. Cure is a term that I use very cautiously. Cure essentially means I'm resetting my heart, making my vessels like, hey, it's back to when I was 20 or 15 or whenever my coronaries were clean. So the answer is no. None of these are cures. So the best analogy I can give you is, this is actually like a talk that I gave to more of the lay audience, but I think it drives home the point and it tells a compelling message. If you have a car that's pretty expensive, all right, or even if it's not, would you just say, all right, I'm going to text and drive because that's really important. I like to drink and drive. I just drive fast. Don't wear a seatbelt. If I have an accident, I'll just go get it fixed, right? There is a role for stents, medications, bypass surgery. Here's the analogy. If you have an accident, you go to a body shop, get this fixed, okay? If you have blockages, etc., you could, go to an interventional cardiologist. That's actually me fixing an RCA. This is bypass surgery, which is another way you could treat, blockages, etc. What we do is similar to having a really cool, high-end body shop. We can fix it, but if you want to take control, you need to drive carefully, right? This is what we do. Hopefully, most of us do when we drive cars. This is really what you should be doing. You just have one body, one life, right? Don't want to mess it up. You have to take control of this, which means what you do matters significantly. Do a check. I talked early on in this talk about, hey, your BMI might be perfect, you might look great, but are you metabolically healthy? This is actually a fairly validated one, so I would say do your check. I'm just going to leave this on for an extra 5 seconds for those that want. I think if you are young enough, at least get your parent or loved one or whoever who's older to ensure that you actually are metabolically healthy. So from a diet standpoint, very simply, eat as much. I mean, we're not all going to go completely plant-based, etc., but whole food plant-based diet, minimize refined foods, minimize your salt and added fats and greasy stuff. Putting it all together, this is a revised food pyramid. And the bulk of what you should eat should be, what you eat should be vegetables and fruits. Top it off with whole grains, green leafy vegetables, legumes, high-fat, whole foods should be really on top. We're talking about a handful of nuts, avocados, etc. I talked about diet a lot. You should also focus on other aspects, including being fit, managing stress. I'm still working on that. Make sure you're well connected, and make sure you get adequate sleep. So with that, I am done. Thank you very much. All right, if there are no questions, it means you guys understood nothing or everything is good. All right. Okay, I didn't set this question up, all right? Okay, I'm just saying that's it. Okay, look, personally, frankly, okay, I would say do the most that you can. For me, I find it very hard. Have you seen the Lay's chips advertisement? It's like, you can't stop with one. Trust me, I didn't grow up this way, right? I like greasy food, I like French fries, I like whatnot, or a lot of bad stuff. My problem is I can't stop with one. So I don't know where to stop. So if you can, more power to you. But for me, the easiest thing is like, I think genuinely, early on is the hardest. The first 3 months, it's like any change in behavior, right? Early on is always hard. Once you kind of internalize it, it's like, frankly, food doesn't tempt me anymore. People are like, oh yeah, you're missing out on all this. I don't feel I'm missing out. I'm very happy with who I am. So I think you have to figure out what works for you, but do the most that you can, really, is the message. Yes, ma'am. Oh, Shiny. Hi.
Your comments on sudden deaths, even among runners and all that, we can see quite a lot.
Yeah. And
That they need to do to prevent.
okay.
These are hardcore people who are into exercise.
Right. I think this oftentimes, you know, I think first of all, thanks for bringing that up. This affects us a lot, right? I mean, because we see this, oh yeah, this person's really healthy, and one day they're there, and the next day they're not there. Couple of things. Number one, multiple reasons for sudden cardiac death. The most common is probably, a heart attack leading to some kind of a rhythm problem. And what we mean by that is ventricular tachycardia or ventricular fibrillation, and people not making it to a place where they can be, quote unquote, saved. So how do we prevent this? Number one, if you're going to embark on a very intense physical regimen, and if you've not been doing this before, I would say, number one, listen to your body, progressive overload, the whole thing, which you can Google and look it up. But I think it's important that you also know your body, right? Ensure that if you're on the wrong side of, I would say, even 20s, early 30s, etc., know your cholesterol. Just today, one of my cardiology colleagues just talked about his cousin who is 30, there's no invasion of privacy, so I can say this, who has a hemoglobin A1C of 13. He was like, healthy, just checked, which basically means, you know, you're a poorly controlled diabetic. So we have a lot of disease that is unrecognized. And in general, in India, I think there's a very, again, I'm not going into the reason, there's a big mistrust of like, you don't want to go to the doctor unless you have a problem. So we don't do, you know, preventative guidelines. People don't know their cholesterol. They don't know that they have blood pressure. They don't know they have high cholesterol or diabetes. And unfortunately, all of these risk factors are silent for the most part till it hits a particular point, and sometimes even then it is not. So you could very well be a sitting duck, and one day you decide, all right, I'm going to go work out, and you push your body, and you're in some place, and you're kind of just doing this whole thing, and you have some symptom, and you think this is not heart disease, because I know what heart attack is supposed to feel like. There are lots of myths about that too. I don't have a crushing pain. It's just heartburn. I thought it was indigestion. It was the biryani I ate last night. I thought I was just winded. And then, you know, it triggers a MI, and then, you know, we don't have a great, robust, EMS system, etc. And even with that, out-of-hospital cardiac arrest, even in the US, survival is about 10%. So I think listening to your body, knowing your risk factors, ensuring that you get checked out before you start any kind of even moderate to intense physical activity. The other thing, of course, the zebras are, some people might have congenital problems, they might have hypertrophic cardiomyopathy, they might have some electrical abnormality, there might be other reasons too, but common things being common, I think if we did this, that would actually make a huge impact in reducing sudden cardiac deaths. Sorry about the long-winded answer. Honestly, does it matter? No, okay. Yeah, so in general, I think we've all recognized that COVID is much more than lung disease, right? I mean, it's I think I'm preaching to the choir, you're all doctors here. So we know that it affects inflammation in multiple, it's an inflammatory process, and it also affects the heart as much as, I would say, the lungs. Certainly increased incidence of myocarditis, more inflammation. We are seeing some inappropriate sinus tachycardia kind of stuff. We're seeing more MIs. It's also a thrombogenic state, basically puts you at a high risk for forming clots, etc. How long the effects last, we don't really know, number one. Number two, you have seen the published literature. Some of the COVID vaccinations might have a slightly increased risk, and, without getting into the politics of it. But overall, I think vaccines helped save lives. So whether we had symptomatic COVID, asymptomatic COVID, I think, unfortunately, most of us have been touched at some point by the virus. So it's just, it is what it is. And you still, there is a role for checking out all your inflammatory markers, your risk factors, et cetera, and doing the best that you can. So it might have contributed, but that's the world we live in post-2019.
Hello. Excuse me.
I need a clarification on one paradox. India, sizably, we have a good number of vegetarian population, but you said again it is a cardiovascular capital.
I could save this for the panel discussion because I'm sure there are going to be more questions on this, if that's okay. But I mean, I'll just address one component of this, and perhaps we'll just bring this up later, just kind of pick people's brains on why this might be the case. Clearly, as South Asians, it's not just nothing special about India. It's Indians, Pakistanis, and this part of the world, Sri Lankans, Bangladeshis. Genetically, I think we are at much higher risk for coronary artery disease. There are no two ways about it. We almost have incidence of coronary artery disease 1 decade before, I would say, the Caucasian population. The reason I'm saying that there's a strong genetic component is that even when, let's say, the people like the second generation Indian Americans, etc., who've been living there, are at a higher risk for coronary artery disease. And perhaps Dr. Spurti could talk about the Stanford Sati and a lot of the stuff that's the Masalas study, etc. So genetically we are out. And plus we add fuel to fire, right? There are some dietary habits. I think overall as children, most of us were just taught to read. Oh, you should spend 1 more hour, get higher marks, and go from second rank to first rank, rather than be physically active. I think overall, if you look at most schools in most parts of the world, there's good emphasis on good active lifestyle from the get-go. It's not like it's a fitness fad doesn't start at 40s. It's like people are fit, they're active from a pretty young age. I think that also perhaps comes back to bite us. The dietary part I'll save for the panel discussion.
Good evening. There's 2 questions here.
Excuse me.
Where?
Oh,
hi.
yes. 2 questions. You said in your lecture, coronary artery disease can be without symptoms. What's the reason and how much percentage is that? And another one is the atherosclerosis can start from the childhood. Is it a myth or correct?
Okay, actually 2 great questions. Hey, Dr. Spurti, are we doing okay on time? I mean, just let me know if I'm okay. So here's the thing. I think most of you here are doctors, right? So, but I will say this in the interest of the non-medicos and a refresher course in our, med school physiology. The heart works incredibly hard. Like when I work out, let's say you go to the gym and you're pumping or you're running, etc. Your skeletal muscles typically can extract more oxygen from the blood. So the arterial oxygenation and the venous oxygen, if you just look at it, it can extract more. The heart always, even at rest, maximally extracts oxygen. And the point being, it's a very flow-dependent organ. So it's a function of, how much oxygen you can extract depends on, in, out, right? It's already doing maximum. So the only way I can improve my oxygenation is by increasing the supply, right? So interestingly, there are certain adaptive mechanisms in the heart. Now, and again, I'm just going to say this, right? If you ever hear, oh, there's a 30% blockage, at least based as of 2024, this statement is true. A 30% blockage, let's say someone has that in their coronary vessels. You should not bypass it. You should not stent it. What you should do is lifestyle changes and medications, because there is no data. A 30% blockage does not affect your blood supply. You will have no symptoms. And in fact, even as the process of atherosclerosis happens, there's what we call positive remodeling. The body tries to ensure that you get enough blood by making these adaptive mechanisms. But at some point, and typically, I'm sure, unfortunately, I'm sure most of you have had relatives or someone who has had an angioplasty or bypass or something. The 70%, there's nothing magical about 70%, okay? 70% blockage or 80% blockage. And what really matters is that you get symptoms when with exertion, there is impaired blood flow distal to the blockage. And this typically happens around the 70% mark, okay? Because before that, if you just have a 50% blockage or a 40% blockage, at rest, at stress, anytime, it doesn't matter. The body continues, the heart continues to get enough oxygen and blood supply. So you have no symptoms. Your second question, yes, the process of atherosclerosis starts early on. Typically as early as in your late teens and 20s, which is why for the young kids sitting out there, if there are any, I know my kids are here, early on, it's like compound interest. I think, you shouldn't, like, the earlier on you intervene, you get good healthy habits, the better off you're going to be. It shouldn't be after the horse is out of the barn. All right? Are we good? Thank you. Yeah, sure.
Is heart attack always a symptom? If you get a chest pain, it is related only to heart attack or any other?
Okay, so again, it just feels like these are all set-up questions, so really appreciate like the easy one. Here's the thing. Chest pain, typically what is described in the textbook, they call it Levine sign, it's like crushing chest pain, in the middle of the chest, going into your left arm with sweating, nausea, blah, blah, blah. Not everyone reads the textbook. In fact, most patients don't get symptoms like this when they have a heart attack. The other end of this, if you look at the other side of the coin, heart pain or chest pain can be due to any number of reasons. It could be due to problems in your foot pipe, musculoskeletal, just feeling depressed. It could be psychosomatic. It could be, it could be anything. So it's really, really, really hard to say if, sometimes when it's very classic, it's easy to tell, but many times it's not. So once again, the take-home message, thanks for bringing that up, is do not try and diagnose this at home, okay? So I said, yeah, I thought this was it. And we have had people that have walked through a heart attack and then come the next day. They're lucky enough to survive it, but with like a crappy heart, like, the heart function has already decreased. They've already lived through a big heart attack. So if in doubt, get checked out. So yeah, I mean, in fact, there was a story last year about a cardiologist who went to the hospital thinking he had a heart attack. First set of everything was normal, goes home to sleep, doesn't wake up because he actually had a heart attack. So if a cardiologist can't diagnose it for himself or herself, good luck, right? So just get checked out. Thanks.
Thank you, Dr. Arun. Am I too loud? I was actually surprised when he didn't get any questions initially. So I was like, huh? So I think everybody's just slowly warming up now. We will have a very brisk panel discussion, I hope. So I would really like a lot of involvement at the end when we are asking, getting questions from you guys. And that's kind of the reason why he didn't want to talk much about the nutrition and the vegetarian question that Doc asked. I'd like to welcome Dr. Regina Shayan, Medical Director, Pan India. Dr. Regina Shayan, one second. She's one of the pioneers in the field of therapeutic lifestyle interventions in India with 2 decades of healthcare experience. She has founded healthcare tech firm Invest on Health in 2015, focusing on lifestyle implementation for chronic diseases. She has pioneered the use of technology in therapeutic lifestyle interventions. She's highly sought after for her perspectives and guidance in the field. She strongly believes in liberating healthcare from fads, tips, tricks, and other vested interests with an intense focus on evidence-based therapeutic approaches to nutrition. As a lifestyle medicine physician, she has championed the cause at various forums, including ISLM, PCRM, and at various corporate organizations, and even at the community level. She has also held the position of Director of Alliance, Advocacy and Membership at ISLM from 2020 to 2022. With a role in Pan India, she's on a mission to educate and empower doctors about the domain of evidence-based nutrition lifestyle interventions as a primary line of management. Colleagues describe her as a catalyst and an ardent advocate of the movement to transform global healthcare systems with nutrition lifestyle interventions at the core matrix. Welcome, Dr. Regina. As we inaugurate our Pan Chennai chapter with our first Chennai CME. We would like to invite a couple of the Pan Chennai co-ambassadors and the team to come up to water the plant. So we're slightly different from the Kuttuvilakku. We're going to try watering the plant, okay? Can I get Dr. Priya on stage, Ms. Shiny, Dr. Jayashree, Dr. Nritya? Can you please come up on stage? Can I have Dr. Ashwini Maran? Is she here today? Okay.
First of all, I'm so happy and super excited to be standing here. I never expected on a Saturday evening having this kind of a crowd, especially with the organizing team, the Chennai team. We're worried whether we will get at least 80 people. But look at the numbers. So excited to be standing here. And my flight also got delayed by 1.5 hours, but I still could make it. Thank you. And all of you are part of the Pan Chennai Association, right? All of you have joined Pan Chennai Association? All of you. Whoever has not joined, please join the group. This is the starting point of this journey. We are starting a Chennai Pan Association. We will have repeated activities, like once in 3-4 months, we will have some kind of a seminar like this, and we will all learn and grow together. So let's all join this group, and whoever has not joined yet, Shruti will be able to, display the group, what do you call that actually, group? What is it called actually, the group message where you can join actually. Anyway, Shruti will facilitate this actually. So I just want him to be. So as Dr. Arun has already mentioned, he has already, I was, towards the end of it only I have seen, but I have seen some of the studies he has already mentioned, the evidence base of it, especially the twin studies. How many of you watched the documentary, the twin studies? Yes. Only one person. How many of you watched, okay, all ISLM people, okay? Anybody watched the documentary, the longevity studies, the Blue Zones? Okay, again, only very few people, okay. So let's get into the presentation. I'm actually a little slow because I just ran and came. Starting with the start, I will be able to go faster. Which med school, which medical college? Which one? Kalpa, okay, great. Kalpaga. Okay, great actually. So what made you guys to come here? What made you guys feel that you want to be attending this? Okay. So you just thought, okay, what is that, something different? So let me go and attend, right? Is that the reason why you came here? Okay. So, evidence-based nutrition is something which I'm going to be discussing here. So, nutrition is something which is practiced by a lot of people. Nutritionists, definitely they are practicing evidence-based nutrition. And our traditional systems of healing, naturopathy, yoga and all, also practices some level of nutrition. So, let's learn or let's understand the basic understanding of what is evidence-based nutrition. That's what I'm going to discuss. And before going in there, I'm actually going to say why doctors needs to be practicing nutrition. Anybody, why all of you came here, why do you feel that you guys need to be practicing nutrition? Anybody, any answers?
Every patient wants to have a good diet. But every disease they will be
Excellent, excellent. So actually that's a condition. I've been practicing nutrition, lifestyle intervention for the last 10, 12 years, and I've been noticing that people come to your clinic. Initially, people used to come for only weight loss, weight reduction. Now people, at least the upper middle class and middle class people, come to you and ask me, Doc, how can you get me out of these medications? So the situation is changing. People want more a holistic approach, nutrition intervention, lifestyle intervention. That's what you're looking for. As Dr. Arun has already mentioned, multiple of those studies already is out. There are documentaries out there. At least the upper segment of the society is aware that there is therapies beyond prescription medications and procedures. That's why people are asking for it. So if you're not learning this, if you're not practicing this, especially the younger crowd, 10 years down the line, we will not be able to compete with the kind of competition in the field. So it's high time that you become part of the movement, learn and practice it. Okay, why nutrition intervention to be at the core metrics of the healthcare system? We have Shiny here, who is a very popular nutritionist. Who I also watch some of her stuff, and we have another rock star here, Dr. Priya Kalyani. Also, I keep seeing a lot of things. Why nutrition should be at the core metrics of the healthcare system? Core metrics means we have nutritionists already doing nutrition intervention, right? Why doctors need to practice? Why doctors need to learn it? Anybody? Okay. And so this slide is familiar to any of you. So there is an obvious epidemiological transition happened over the last 30 years. We used to have a major healthcare burden which is coming from basically communicable diseases, accidents and injuries, which has shifted to non-communicable diseases. It used to be more of a problem in the West. Right now we have 66% of our burden in India itself is caused by non-communicable diseases. Globally it is 74 or even 75%. And we also have another set of challenges which is coming up now, which is related to climate change. Anybody aware of climate change related disasters? Anybody came across anything or read anything? Right? So it is something which is coming up, which is in a big way, especially in the West. We do have problems in the, like North India, especially towards the Himalayan regions and all. Actually, there are reports of drought, flood, heat stroke, multiple of those kind of things actually. And then we have another issue which is very new, which is antibiotic resistance. When we were doing medicine 20, 25 years back, we never learned much about antibiotic resistance. Now it is a major thing. Multiple organizations are there to address this issue. Then we have zoonosis and pandemic risk, which we just came out of one just recently. We are aware that actually. And food insecurity and undernutrition, it was always a problem, but it is more, we are more aware right now. But when you look at all these issues, one side of it NCDs, which is 66% of the issue, when we have the newer issues, when you look at it, there is a common thread. What is a common thread? Our food system, yes. The way we eat is the major reason for all these issues. So it is something which has to be addressed. And it has to be addressed by the healthcare system. Why the healthcare system? Because we being at the apex of the healthcare system, people will listen to us. And it's not like just sitting at a clinic and prescribing a medication to a patient, but as advocates and as influencers who can really influence not only people, but also the policymakers and industry players. That is why doctors needs to learn nutrition. And on top of it, you already would have learned this, that any diseases, NCD, chronic diseases, the kind of management should be managing or addressing the root cause of the illness. There are like different causes, distal causes, medial causes, proximal causes, but as doctors, we are only managing the risk factors. As Dr. Arun has already mentioned, so, you know, there is role for medication, there is role for other procedures, but reserve that for only those which require that, actually, not give for everybody for the same kind of medication. Recently in June, there is a study which came up which says that the eligibility, statin eligibility, the people who are getting statin, I think 60% or more, are not eligible for it. We are overdosing people. Instead, we should be actually addressing the root cause at the first place. Why we are not addressing the root causes? Anybody? Anybody? A lot of practitioners are there, a lot of medical students are there. Why you're not answering? Okay, so first line of management, it should be nutrition or lifestyle intervention. Medical therapy has its role, surgeries and procedures has its role, but it has to be reserved, it has to be optimized. Don't give everybody the same kind of medications and procedures. Where you can actually go beyond giving medications and you can actually coach them to be a better people, and not just but survive with medications, but you can also make them thrive, help them with achieving different, not only health related goals, but also multiple other goals. And when we talk about nutrition to doctors, the first thing, not only common man, but first thing comes from doctors is actually nutrition is unbelievably confusing. I really don't understand this thing at all. Why we don't understand this? Because we haven't learned this in a structured manner in our med schools actually. And we don't have any CMEs like this on nutrition. So naturally, we are not equipped to really understand these things or practice this thing. That is why this kind of a seminar is very important, and being part of the movement is very important. And yeah, how many of you followed a keto diet? Just raise your hand. No? Surprising. I normally get at least 25% of the crowd followed some kind of a diet. Any dietary pattern anybody followed in this room? Vegan diet, keto diet, Atkins diet. Okay, yes. Sure. Oh, okay, great. How many of you followed intermittent fasting? Great. Oh, okay. Okay, nice. Okay, so there are 101 dietary patterns out there, and we don't know, as doctors, we don't know which one is good because we don't have the fundamental knowledge in analyzing nutrition or understanding nutrition. And on top of it, actually, common man get confused because the nutrition knowledge is given to the common man by the social media influencers, not like Dr. Shaini or Dr. Priya, but those ones who doesn't have a formal education in nutrition or medicine. They just read something and put out stuff there. You need to be having at least 1.5 gram per kg body weight of proteins a day. And I have clients who are coming to me and who are eating like 250 grams of chicken or 200 grams of paneer a day, which is raising their LDL cholesterol, which is raising their saturated fat intake to a large extent, and leading to LDL cholesterol increase and atherosclerosis. This is not known to them. They know only that muscle and proteins actually. So that is what is happening. And then they go to the doctor, and the doctor will say that, hey, you have to lose weight. You have to do exercise. That's all the doctor knows actually, because we are not adequately prepared to manage nutrition. We are not trained to do that. And we have done a study why PAN came into the forefront in this moment is actually PAN has already started this in 2018 in Germany, and they wanted to do it in India because India is a country where multiple dietary patterns, multiple therapeutic patterns exist. So they wanted to do a study whether it is something which is feasible. And we did a KABP study, and we found out that, like some 600 or 300 doctors we interviewed, and found out that doctors already know that nutrition has to be the primary line of management. It has to be taught to the people, but they are inadequately prepared. At the same time, what is happening is a patient who has a diabetic issue or a cholesterol issue or cardiovascular issue goes to the cardiologist or internal medicine doctor. The doctor will decide whether he has to go to the nutritionist or not. So 100 people goes there, maybe 5 or 6 goes to the nutritionist. So it is like a kind of not an efficient system. And at the same time, a nutritionist gives a nutrition plan, except very few people who are really working at a much intensive model. They give a dietary pattern, people don't follow it actually. So naturally it is said, yeah, okay, diet is something which will not work. Okay, so that is the kind of system which is existing, and the doctors, they say that the doctors being at the apex of the healthcare system, people will listen to us and they will start, they will start following it more religiously and will get result. This is what, and they're also saying that the doctors, each one of you, once you learn nutrition effectively, you're not just going to be sitting in a clinic, just not going to be sitting in a clinic and prescribing nutrition and other medications. You will also be able to advocate for the same in multiple social media platforms or in public speaking, or you can be part of a, you can influence FSSAI, you can influence NIN, multiple of those things, because as a profession, we do have the respect. We are actually taken seriously by not only public, but also by the policymakers. Understanding history of nutrition, when we think about nutrition, it's better because it's very confusing. It's better we know about nutrition. I think Dr. Spurti and Dr. Arun were in the US when these movements were going on. They know a lot more than this, but let me put some information about how the nutrition, modern nutrition has evolved over the last 2-3 decades. So the modern nutrition, the history of modern nutrition, they say that it started in 1910 to 1930s or something, when the deficiency manifestations were very prominent, like vitamin C deficiency, vitamin B1, thiamine deficiency, and people were suffering from that. And that started with the British soldiers. They started noticing a lot of issues and found out that actually, one of the a nutrient like vitamin B1 or C could be the reason. And then they isolated it actually. And then once they started giving these nutrients in the form of supplements or fortified stuff, people started getting better. So what happened is actually nutrition has become some problem. You're giving a supplement. You're giving a supplement, people get better. The same thing was carried on to NCD. When in America in 1950s, they started getting a lot of heart attack. They wanted to learn and understand what is the reason for these heart attacks. They put together multiple teams. One of them, we all have learned, Framingham study, 7-country study. Multiple of these studies were happening during that time. But what happened is actually the focus was, okay, nutritional deficiency, the same focus was carried on to those studies actually. It was like a single nutrient focus. So here, okay, fat is a major cause for the disease, or sugar is a major cause for the disease, or saturated fat, trans fat, all these kind of things were more prominent. But this was right, but it was given a hyper focus. Then by 70s to 90s, focus on NCD on one part of the world. Western world was focusing a lot on NCD reduction by giving a low-fat diet. But the low-fat diet, what happened is actually went very popular, and it also was able to bring down some changes in the heart disease and things like that. But industry always comes into the picture. So what happened actually, industry people started selling a lot of products, which is like low fat with the label, but they have started including a lot of sugar and high fructose corn syrup in the thing to give addictive behavior for people actually. So that resulted in obesity and diabetes and things like that. So another set of problems happened. So then that one came into the thing that, okay, this is causing problem, fat is bad, and hence so sugar is bad or carbohydrate is bad. So LCHF came into the picture, or keto became very popular and stuff. So there is an evolution. The evolution has a very strong history of some kind of diseases or some kind of research associated with it. It's not something which is really confusing or bad. It was just evolution of a modern nutrition science. By 90s to present, we all know that, a lot of us would be aware that many of these studies came into the picture by 80s or late 90s and stuff. Any of you know about nurses study 2, healthcare study, professional study, healthcare professional follow-up study. Some of these studies are like 30, 35 years old, and it is done in lakhs of population. These are epidemiological studies, which are observational studies, cohort studies and stuff. When we talk about the evidence of evidence-based nutrition or predominantly plant-based nutrition, one of the major setback we get from the medical fraternities, oh, these are observational studies. We don't have much in RCTs and other things in nutrition studies. That's true because the evolution of nutrition itself was actually based on these observational studies, these epidemiological observational studies. We couldn't focus on RCTs because that was not a major thing. And second part is actually you need to think about nutrition as something, not just a single entity, right? So it is like now we are at a place where nutrition, we are seeing nutrition as something, it's a dietary pattern. Single nutrient has gone to a dietary pattern. We have analyzed enough and more dietary patterns over the years, and we found that a plant predominant eating pattern is definitely helping people to get healthier, reduces the risk of heart disease and stroke and things like that. Some of them you already know, which is Mediterranean diet, DASH diet. Mediterranean diet is something which is extensively studied for the last 30 years or so. So RCTs were not possible because RCTs were, ethically not always correct. Putting a person to, some of these studies has to be like 10 years, 15 years and all. And knowing this, nobody would be ready to do a practical problem. Nobody would be ready to go for that kind of a diet for a longer duration. Second one is, ethically it is not right. Will you be ready to put your family person to a dietary pattern which hypothesized to be like causing a heart disease? I will not do it. So it was not possible. So now we have a lot of systematic reviews and meta-analysis which is coming in. So this is actually one of the studies which people who are interested in nutrition should know, because this is the basis of the recent recommendations across the globe. Actually, this is called a global burden of diseases study, which was done by IHMA, and also like Walter Willett and many of those prominent nutrition scientists has already been a part of this particular study, and it is the most comprehensive worldwide observation study which was done so far. Till this time, it was like first report came in 2019, the latest one in 2021, and now also there is another report which is coming in. It was done in 204 countries, 88 risk factors were identified, 15 of them were dietary risk factors. From that, we really understood that it's not just about eating higher quantities of saturated fat or trans fat, or processed meat and red meat and sodium and stuff. It is also about not eating enough of what is required for the body, like vegetables, fruits, nuts, seeds, whole grains, legumes. If you're not eating that, even if you're consuming lesser of the other things, you still will not have an optimal health. Okay, that is the understanding that currently we have from this study, right? So the guideline also changed based on this. You can see that, how many of you have seen the ICMR's latest guideline? Okay, so ICMR has come up with the latest, yeah, I've seen some, good. So ICMR has come up with the latest guideline, which is also aligning with what it says. And so this is something which I wanted you guys to know, that like nutrition studies has kind of, there's an explosion of science in nutrition. Like every decade, if you see that, it is doubling and tripling. So that we have lots and lots and lots of data. As doctors, we need to know how to analyze this and make sense out of it and give evidence-based prescription to our patients. As this I've already mentioned. Anyway, this systematic review and meta-analysis is something which is very authentic, or which is very well accepted in the nutrition science, evidence-based aspect of nutrition. And there are many of them available right now. When there is a confusion, please go for the systematic reviews and meta-analysis. I'll give you a simple example to understand. There is a cholesterol controversy. I know that there are people who still believes that saturated fat may not be that bad, because there were like all these 60, 70 years of research shows that fat was bad, and later saturated fat was bad, and there is all the guidelines say that you need to restrict saturated fat intake. What does AHA says? American Heart Association says 5 to 6% of the total calories. Other things are saying like 10% of the total calories, right? So, but what happened is there was a lot of confusion because there were few studies which came, even one of the sub-study from the 7-country study, which said that it's not saturated fat which is bad, it's a trans fat which is bad, and saturated fat is like blamed for it, it's not the real truth. And there were some books came, which is like one prominent cardiologist and prominent nutritionist. So it was cholesterol myth, and multiple of those books came into the picture. People started thinking that, okay, it's wrong science, you know, we always blamed saturated fat. Then actually this was going on, and even the cardiologists, some of the prominent cardiologists even whom I know started recommending a lot of animal fat, animal food, and even coconut oil for people, thinking that saturated fat is not that bad. And then 2018, 2019, American Heart Association came with a systematic review and meta-analysis, which has shown that saturated fat coming from any source, even plant-based source or even animal-based source, is really bad. It is, if it is coming from dairy or coconut oil or animal fat, irrespective of that, it is causing heart disease or LDL increase and atherosclerosis. So some of these things we should not be just looking at one study. We should be looking at what's going on in the field and what is the current thing. A systematic review and meta-analysis is something which you should be looking at more often. And then based on that, you know, your clinical experience, you make some kind of a, logical conclusions and help the patient to get better. Sometimes it's not always that, okay, a diabetes can be reversible or a heart disease can be reversible. It can be like making the patient better cope with the situation sometimes. It can prevent, sometimes it can reverse, but many a times it is like helping them to cope with the situation. So nutrition has a role not just at one place, it is at multiple places, right? Evidence-based nutrition, where are we currently? This is something which I put together from my understanding of the last 10 years, 10 to 12 years of research, understanding. At the same time, I've also taken some inputs from Dr. Muzaffarin's presentations. So nutrition has gone beyond calorie intake, calorie in, calorie out. We are very clear that 200 calories of donut and 200 calories of fruit does to the body is very different. So that is very clearly understandable. Second one is actually defining a healthy diet. It's gone just beyond the single nutrient aspect, and it has gone to dietary patterns. Overall dietary pattern is more important than single nutrient or some nutrient supplementation. And we are also very clear that it's not a linear relationship. You're eating refined grains, you know, bad saturated fat. Sometimes some people don't have any diseases. So it's not just a linear relationship. It is much complex than that. We don't have understanding of that, but there are lots and lots of studies coming in, which will help us to understand these things better. And some of these things are very emerging. As doctors, as following evidence-based nutrition, we should not be making very strong claims about these things because we need to have more and more studies coming into the thing. Microbiome, we know that it is helping us with our digestive system. It's also helping us with producing short-chain fatty acid, help with preventing cancer. These are all early stages of research. We need more and more research to make very conclusive statements about it. Intermittent fasting, there are a lot of studies coming in. It's all promising. Again, it's an emerging area. Phenolic compound, bioactives, it's plants which is coming from plants, is definitely very helpful. But again, it is promising. We need to be really waiting for more studies because one side of it says that phenolic compounds and bioactives and flavonoids are very helpful in multiple conditions, optimizing health. The other side, it's saying that if you're consuming large quantities of these, you are going to be having anti-nutrients and absorption of nutrients get affected. So we need to be more cautious and, you know, like advising a patient to have this kind of a particular, maybe chia seeds or millet in large quantities because we need to have more data coming in. So this is something which makes sense. So beneficial nutrients of productive foods are the ones on green: fruits, vegetables, whole grains, nuts, seeds, herbs, and spices, because these are, again, the newest research, which is saying that they are high in bioactives like flavonoids and phytonutrients and fiber, and slow in digestion. And at the same time, you need to understand that any seed of it can give rise to another life. The ones down, which is red, has to be completely avoided. It's always better to completely avoid those things if you are concerned about your health or your family's health. The other ones, the other fish and yogurt, there are a lot of controversy, and fish definitely is something which needs to be thought about as doctors and as individuals. Our health is not just about, having some healthy, beneficial thing. It's also about the planetary health, actually. Some of these things, if you look at some of the recent things, one of the videos I was watching, there was a fishing which was happening in the Mediterranean region. After 80th time, they're not getting a single fish because our oceans are actually depleted of fish. So this is that we are over-consuming these things. We are actually exploiting our nature. So that is something to be thought about. At the same time, on the health aspect, some of these fish are also coming with a lot of loaded with heavy metals. That also needs to be thought about. Butter, ghee, and all. It's very simple technique. Butter, paneer, ghee, and things like that is very high in saturated fat. 1 tablespoon of ghee has around 7.8 grams of saturated fat. AHA recommends like 12, 13. You're already like with 1 tablespoon of ghee, you're already at 8. We have some of the doctors in Jaipur, we were like just doing a survey. Most of them are eating like 2 to 3 tablespoons of ghee a day, which is already crossing the upper limit. So this is something which should be known to us as doctors. And dietary guidelines, as I mentioned, all the dietary guidelines are saying a predominantly plant-based eating pattern. Eat more vegetables, fruits, legumes, nuts, seeds, whole grains, and less of animal products. If possible, cut down completely. Indian diet, how many of you think that Indian diet is the best diet? Okay, let's analyze what it is actually, okay? Maybe it was good maybe 20, 30 years ago for a population which was more of very active agrarian economy, which is not very sedentary and things like that, right? Let's look at our problems. We have triple burden of malnutrition. One side of it, NCD, 66% of the problem. We have nutrition deficiency, which we haven't corrected yet. Okay, as per the reports, we are not at a level where we have to be reaching right now. And we also have problems with hidden hunger. That means like micronutrient deficiency. So GBD study says that 1,000 plus people per 1 lakh population is having problem with DALI, the disease adjusted life years. It's 1,000 plus 1 lakh for nutritional deficiency. For NCD, it is 2.5K, 2,489 DALI per 1 lakh. So if our diet was good, we shouldn't be having these problems, right? So let's look at what evidence says. So Eat-Lancet Commission has done the comparison of our diet with the reference diet. It says that we are consuming only 40 to 50% of the vegetable which is required for our daily consumption, and fruits and vegetables. We are over-consuming our grains in the form of refined white grains. We are eating a lot of oil. We are under-consuming our proteins. We are under-consuming our proteins because we are over-consuming our grains. We are not giving it space for legumes, nuts, and seeds to come in. Look at the Kerala plate or Tamil Nadu plate. You can see that 80% of the plate is white rice or related stuff, right? We need to change this, right? And now, how many of you, and we are also 10% to 15% of our younger population's calorie intake is coming from packaged food, right? Which is high in sodium and trans fat. Now, how many of you feel that our diet is not that right? Good, okay. And at the same time, look at the pattern of animal product consumption. In 30 years, the consumption of dairy product has kind of tripled, or even 4 times actually. And India actually has a growing appetite for meat. Doubled actually. Most of the studies says that we are consuming almost double the quantity which we used to consume 30 years ago. So something which needs to be during this time frame is where all these epidemiological transition happened, 1990s to 2000. If you look at it, the dietary pattern transition also happened during that period. There should be connections. We haven't studied it. As young doctors, you should be studying this and find out whether there is a correlation or a causality. Plant-based diet, I think Dr. Arun has done enough and more of this. I think I'll just skip through this. Yeah, we have like history of plant-based diet starting from 1950s, which started with reducing saturated fat intake. Saturated fat predominantly comes from animal products like dairy and meat, and then tropical oils like coconut oil and palm oil and stuff. So then, like we have done a lot of studies on Mediterranean diet, DASH diet, MIME diet, even vegetarian diet, which are considered plant-based because it is predominantly plant-based. And then by 80s to 2000 time frame, we had a set of scientists which came. Dr. Arun has already mentioned about Fox overnight. People who haven't watched that, it's available, I think, on Netflix. Please watch that. So it's just showing how two scientists, one was a cardiologist, Carlville Esselstyn, he has shown a arterial change video, picture, and on the other side, a nutrition scientist, T. Colin Campbell, they came together and found out that this kind of a dietary pattern, whole food plant-based eating pattern, is not only helping us to kind of prevent diseases, but also in certain cases reverse diseases actually. So there is something called China study. Again, it is, I think we can actually share these things as a list of things in the group so that you can watch it actually. So that also is something which you should be watching it. And evidence-based WFPB is not only about the documentaries. That documentary is just giving an initial understanding of that so that you feel that you want to learn more about it. And if you feel that you want to learn more about it, I'm sure that it will suck you in. You will love it actually, because then comes the nurses study, Adventist study, all of these studies. At the same time, as I already mentioned, like a plant-based eating pattern is, a whole food plant-based eating pattern is less than, devoid of saturated fat, trans fat, sodium and other things, but at the same time high in phytonutrients and fiber. And we do have a lot of RCTs coming in, especially after COVID. And one of them, old RCT, which can be mentioned here, which is called portfolio trial, which is about cholesterol reduction, comparing with a portfolio diet, which is a plant-based diet, comparing that with a statin and a standard reference diet. And actually the result is in 4 weeks, the result is almost similar, statin and the diet. So some of these things are not known to us as doctors, because we always look down nutrition as something, it's not something which requires attention, right? But if you don't do it, another 10 years, somebody else will take up. And our role as healers and as doctors, we will not be having this kind of a position in the society, because people are looking for holistic solutions to their problems. Transitioning to PBD is not just about individual health, as I mentioned. A lot of other interconnected factors are there, as I mentioned, planetary health. So food system constitute 33% of the greenhouse gas emissions. 18% is caused by animal husbandry. Once we cut down those things, the planet gets better, heals better. So this is something, this message has to be taken seriously. The best way to be part of the solution is to join us, to be involved with us in multiple capacities. There are journal clubs, there are discussion forums, many ways you can be involved with us, learn with us together, and make some changes in the world. Thank you. Thank you so much.
Thank you, Dr. Regina, for that very enlightening speech. So we keep hearing the words plant-based. So from tomorrow, French fries, ketchup, bread and jam. We're good, right? Yes? Thank you. We need to start the conference right from the beginning, I think. So the key word here is whole food, plant-based, WFPB. Whole food is, the unprocessed grains that we are seeing, and plant-based. So please don't start off with your French fries and ketchup. I'm going to invite Dr. Jayashree Gopal. Dr. Jayashree Gopal is Director, Endo India Chennai, which is an institute for diabetes, endocrine, metabolic, and lifestyle health. She's the founder trustee of Endo India Foundation, with its phrase, preserving health across generations. She's a diplomate of the American Board in Internal Medicine, Endocrinology, and Diabetes. She's a senior consultant endocrinologist and diabetologist at Apollo Hospital, Chennai. She's also the vice president of the Endocrine Society of Tamil Nadu and Puducherry, the recipient of the Vocational Excellence Award from Rotary Club, and awarded the Dr. Sam G.P. Moses Oration at the API Chennai Chapter Annual Conference. Welcome, Dr. Jayashree Gopal.
Good evening. First of all, congratulations to Dr. Spurti, Dr. Arun, Dr. Regina for starting up the Chennai chapter of PAN. And I do look forward to being associated. So it's good to know. It's a common complaint among doctors. We don't learn about nutrition. So I'm glad that there is an organization that is going to teach us about nutrition. I think that's very important. And I would also like to thank Dr. Spurti and also Shiny for putting some questions to me. So what I'll be talking about today is common questions that I get asked every day. And it helped me go do a deep dive into, things that I knew, but I wanted to get the evidence-based nutrition out of it. And for all of the medical students here, I think the only thing I would say is don't accept anything at face value. I think that holds true for all of us. You have the internet at your fingertips. All of you are far more savvy about using it than people of my generation. So do a deep dive, go back, and I'll show you some data from way back that, supports or does not support things that we believe as gospel truth. So I'm going to be talking about some nutritional factors in thyroid and some myths, very commonly held myths. In fact, I was just talking with my husband today about this, and he said, the only thing I remember about thyroid from medical college is being told after thyroid surgery, tell patients not to eat cabbage and cauliflower. He said, that's the only thing I remember. So let's talk about it. And this very important question that I get asked every single day, can I cure my thyroid, doctor, through diet and lifestyle? We know it works for diabetes. We know it works for cholesterol. You heard Dr. Arun show that wonderful angiogram that a plant-based diet or any sort of healthy diet, I would say, reverses even cardiovascular blocks. Can we do the same for thyroid? And is there any evidence available? And I'll be talking about that. I just will spend a few slides talking about the gut health and diabetes. So before I go into it, a little bit of digression into some academic thing, because I'm fascinated by this, and the reason I'll tell you why I'm fascinated by it. So this is a picture of the thyrocyte, the thyroid cell. The iodide enters the cell in the form of I- iodide, helped by what's called the sodium iodide symporter. So you need this very important receptor to pull the sodium and the iodide into the cell, so the plus and the minus. This iodide then enters the colloid, which is right here, the colloid part of it, which is where the thyroglobulin is sitting inside the colloid. And this is done by this receptor called the pendrin gene. And if there are mutations here or here, people land up with hypothyroidism. But what I'm fascinated by is this change. I don't know how many of you remember chemistry. Iodine is one of these molecules that loves electrons. It loves to suck in electrons. It's got one electron missing from its outermost orbit, so it likes to pull in electrons. It loves to stay in the I- state. So you can imagine the amount of work the thyroid gland has to do to remove that one electron from I- to make it I0 iodine, because this is the form, the iodine, that then gets attached onto the tyrosine molecule in the thyroglobulin. So this is the tyrosine molecule represented here. And 1 iodine, 2 iodine, 3 triiodotyrosine, 4 tetraiodotyrosine, which is thyroxine, gets formed. Okay? But this step, going from the I- to I0, is an oxidative step. And this is where a lot of H2O2 is generated. You keep that in mind. And this is done by this enzyme that we all hear about, because we keep talking about anti-TPO antibodies. But thyroid peroxidase is the enzyme that converts the I- to I0 and then puts that, when I say I0, I mean iodine, into the tyrosine molecule. So remember this about the thyroid. So let's first talk about, so these are some of the sort of common things that we think about when we think about thyroid and nutrition. And let's first talk about iodine and iodized salt. A very common question that people ask is iodized salt bad for me? Should I switch over to non-iodized salt? So this thing, I mean, of course we need iodine. We need iodine because otherwise our body cannot make thyroid hormone. We all know about the importance of thyroid hormone in our health. However, iodine needs to be in that beautiful, everything in our body is about balance. I think we know that. Sugars have to be in that beautiful range. Sodium has to be in that beautiful range. Potassium, everything, including iodine. If you have iodine levels which are higher than normal, it causes problems with the thyroid. If you have iodine levels below normal, it causes problems with the thyroid, which is why I put damned if you do and damned if you don't. You need iodine, but excess iodine is bad for you. Now, anytime iodized salt is introduced in any population that did not have iodized salt earlier, so in India this happened in the early 80s, Before that, we did not have iodized salt. So iodized salt was introduced in India in the early mid-80s, I think. After that, in studies around the world, it is shown that as soon as iodized salt is introduced, for the first 5 to 10 years after you introduce iodized salt, there will be a spike in the number of people who have positive thyroid antibodies. It will be there for 5 to 10 years and then it will settle down. So it does not mean that iodized salt is bad. It is the reaction of the population immunity as a whole to the introduction of something which it did not have. Okay, but we need this. After that, it settles down. It is not associated with an increase in the prevalence of goiter or hypothyroidism or other diseases later on. Like I said, we do need iodine. Without iodine, if our gland cannot make it, we have hypothyroidism. We cannot live without it. How much iodine do we need? We determine if we have adequate iodine if your urinary iodine concentration is between 100 to 200 microgram per liter. That means you have adequate iodine in the diet. And what is recommended is that if you're living in a country that does not have an iodine fortified food supply, India does not have it. I mean, we have iodized salt, but not other countries, for example, have iodine in the milk. They have other iodized things, but in our country, we only have iodized salt. If they also avoid the main food sources of iodine, for example, milk and other dairy products, seafood, eggs, and if you do not use iodized salt, you should take something which gives you at least 150 micrograms of iodine a day, particularly when you're planning pregnancy. Iodine is so important for the baby's brain development. The developing fetus requires iodine, thyroid hormone for the brain development. So it is important that particularly pregnant women are supplemented with iodine. There was a good study done comparing the iodine status of vegans who are using some supplement like algae to give their iodine versus vegans who are not using algae versus fish eaters. And you can clearly see that the fish eaters have a higher level of iodine as compared to vegans who are not taking any algae. So it is important if you are, one of the important elements that needs to be replaced in your diet in case you're avoiding all foods of animal origin, I would say, is making sure that you're getting adequate iodine. This is a WHO recommendation for iodine. For adults, it's 150 micrograms. For pregnant and lactating women, it's 250 micrograms. Now, one important thing that has always fascinated me is that I said iodine is a very reactive molecule. When you cook food, iodine is lost. So this study showed the extent of iodine that you lose depending on different types of cooking. And this was a study done in India. So they did the usual Indian food stuff. So they calculated iodine loss after making chapatis, after making chana, after I think, I forgot what else they made for the various types of cooking. But you can see that shallow frying only led to a loss of about 7% of iodine. And this went all the way up to 50% in pressure cooking. So it is important to understand that if the longer we cook something with salt in it, the more iodine you're going to lose. So even if you're using iodized salt, if you've boiled it for more than about, say, 20 minutes or half an hour, you're going to be losing at least 40% of that iodine. What does it mean to us practically as practicing physicians? Quarter teaspoon of iodized salt contains about 60 micrograms, which means 1 teaspoon of iodized salt per day will give you all the iodine that you need for the most part. Another simple tip that I think is helpful is to add salt at the end of the cooking. You know, all of us who cook will know that we tend to add salt right at the beginning. Keep the salt addition to the very end. You know, the remaining like 2-3 minutes of boiling which is there, you add your salt to the cooking. Or even better, just add salt to taste when you sit down to eat. That way, anyway, you would consume less salt. So this is as far as iodine is concerned. Now, this very important question, and I have to mention it here, does thyroid cause weight gain? How many of you think thyroid problems causes weight gain? Oh, I'm very glad. I thought the vast majority would put it up. Okay, there is a little bit of weight gain, but that's just water retention. Thyroid hypothyroidism does not lead to, you know, the problem that most of us are facing nowadays, which is excessive weight gain, obesity, excessive abdominal fat. When you have an underactive thyroid, your body tends to retain more water. When you replace the thyroid, that water retention goes away. Studies have clearly shown that when you gain weight, your TSH goes up. When you lose weight, your TSH comes down, even without replacing thyroid. So if you have a marginal elevation of the TSH in a woman or a man who's gained weight recently, who has no other pressing indication to treat that elevated TSH. You know, if it's a woman, they're not planning a pregnancy or they're not pregnant, there is no other pressing indication to treat that elevated TSH. Please wait, help them lose weight, and then repeat the TSH, and quite often it will settle back to normal, and we'll talk about that. The other important thing to keep in mind is anytime a person gains weight, they'll require a higher thyroid tablet dosage. When they lose weight, they'll require a lower thyroid tablet dosage. Iron and thyroid, I wanted to talk about this a little bit. We don't think about it often, but the TPO enzyme that I was talking about earlier is only activated after it combines to a prosthetic heme group that contains iron. So if you have iron deficiency, the TPO doesn't get activated, which means that whole process of thyroid synthesis does not occur. So you need adequate iron for thyroid hormone synthesis. When you have iron deficiency, it reduces your T3 and T4 levels and it increases your TSH. And the other sort of correlation or relation between thyroid and iron is quite often after you've treated the hypothyroidism, a lot of women continue to have symptoms of hypothyroidism, tiredness, fatigue, leg pain, bone pain, and that's because of iron deficiency. Think about it and treat it. Again, practical points. Remember that severe deficiency of iron can present a subclinical hypothyroidism-like values. So, the typical picture you would see is a woman in her late 40s who comes in with severe bleeding with a hemoglobin of 6 or 7. Her TSH will be 8 or 9, and usually they get referred because they're going to go for like a uterus surgery, some sort of fibroid removal or a hysterectomy, and the question is, can she be taken up for surgery because the hemoglobin is 8 or 9. The hemoglobin is 8 or 9 because the thyroid gland is not able to work properly because of the low iron. So in all of these women, yes, treat the thyroid till the surgery is over, but once they are hemoglobin replete, once their iron status improves, stop the thyroid tablet and see if their thyroid hormone synthesis is back to normal. And I think it's also important to all women with autoimmune thyroid disease or hypothyroidism, please check their iron status. Selenium. Every day someone comes and says, I'm taking Brazil nuts, I'm taking, selenium supplements, can I take it? What is interesting is that the thyroid gland contains the highest concentration of selenium in the body. Even if your whole body is selenium deficient, the thyroid will hold on to selenium. Why? Because selenium is needed for the action of these two very important hormones, enzymes in the thyroid gland. One is the deiodinase. Deiodinase is the one that removes the iodine from your T3, T4, goes back to T1, T2, but also the glutathione peroxidase. So the glutathione peroxidase, remember I spoke to you about H2O2. H2O2 is constantly generated in our thyroid gland because that is part of the critical step in making the thyroid hormone. That's a constant thing. One of the organs in our body where possibly the concentration of H2O2 and therefore other reactive oxygen species is the highest. So glutathione peroxidase is a very important enzyme which removes excess H2O2 from the body, and that glutathione peroxidase needs selenium to work properly. So yes, selenium also needs to be in a proper Goldilocks zone. When you have selenium deficiency, it's associated with hypothyroidism, Graves, thyroid cancer, and supplementation with 100 microgram twice daily of selenium has been shown to improve Graves' eye disease. It helps to reduce thyroid antibody levels and has shown an improvement in thyroid echogenicity. So selenium is useful, selenium supplementation is good. However, selenium varies very vastly from one part of the world. I didn't specifically look at selenium levels in India. There are probably studies about it. But just to say that, for example, if you take cereals and grains, the best source of selenium is organ meats, but let's say you're not going to have that. Cereals and grains, you can see that there is a big difference. So Canada has a much better level of selenium in their crops as compared to UK. So this is obviously to do with, the selenium content of the soil and the amount of, how many years have they been growing the crop so that the soil has been depleted of selenium. What do we eat for selenium? This is a common question I get asked. The Brazil nuts. This is the recommended intake. Somewhere around 50 to 70 microgram per day is the RDA, recommended daily allowance. And one Brazil nut per day gives you this sort of thing, unless you're taking a multivitamin which also contains it, which is, I suppose, okay. But if you want to do it the natural way, one Brazil nut, be careful that you're not taking large amounts of Brazil nuts because there is a variation in the amount of selenium that it contains. And secondly, apparently Brazil nuts also contain a lot of barium. And if you land up eating too much of it, you're going to get barium toxicity. So maybe the nutritionist can tell me, more about that. But basically, yes, Brazil nuts, helpful, one Brazil nut a day if you want to. Now, the one which is the most, I think lots of doctors also believe this, about the Brassica family and the thyroid. So the brassica family refers to all of these vegetables: cabbage, cauliflower, Brussels sprouts, red cabbage, bok choy, broccoli. They all have a slightly bitter taste, and they have a, that smell. Some people just can't stand it. It's a sulfurous smell. But it contains these wonderfully anti-carcinogenic chemicals. They prevent cancer, called isothiocyanates. There are these other chemicals which are the precursors for these isothiocyanates. These are called glucosinolates. And these glucosinolates, if they get converted to something called thiocyanate, I don't know, again, how many of you remember your chemistry? There's just a little bit of difference. The order in which the nitrogen, carbon, and sulfur sits in it will determine whether it's a thiocyanate or isothiocyanate. Isothiocyanate is good, thiocyanate is bad. Thiocyanates can interfere with the sodium iodide symphoter. You remember the one that I said pushes the iodine into the thyroid cell. It also inhibits the all-important thyroid peroxidase activity. So yes, these vegetables potentially contain something which could be converted to thiocyanates. So these glucosinolates can either be converted to isothiocyanates after cooking and chewing, which are anti-carcinogenic, very helpful, very useful in our body. But some of them can be converted to potentially goitrogenic substances like thiocyanate and something called goitrin. So I put this up just for a little bit of relief. This is a picture from 1948 of the Indian hockey team, who by 1948 had won the Olympic gold for the 4th time. I don't think we've ever replicated it. They went on to win 2 more, I believe. But yeah, this is just a picture from that. Why I put this up was because of this wonderful study, which was also published in 1948. And you can see the title, The Antithyroid Effect of Certain Foods in Man is Determined with Radioactive Iodine. You should all be glad you're not medical students in 1948. This study was done in medical students, medical technicians. It was done, I think, I can't remember, I think somewhere in the US. I think it was Johns Hopkins, I cannot remember. What they did was they injected the student, or they would have injected you with I-131, okay? And then they made you go and eat different foods. So 61 foods were tested in 100 different subjects. So they were administered I-131 and then asked to eat all of these vegetables, 61 different types of foods. And then they went and they saw how much the iodine uptake was inhibited. I think it's a wonderful study, actually. It's a wonderful study, can never be replicated in this day and age. You cannot justify giving somebody I-131, obviously, and I don't know how many would volunteer for this. But please pull up this paper. It is available online. If anybody wants, I'm happy to send the PDF. I think it is behind a paywall. If you're part of the Endocrine Society, you can get it. But I put this up to show you. So if you look at these numbers here, it will show you how much the uptake of iodine gets inhibited. And it was highest with this vegetable called rutabaga. I'll come to that in a minute. You can see that with cauliflower, there is absolutely no reduction in uptake. All of the iodine got taken up. Cabbage, most of the cabbage forms, absolutely no. So 0 was good. 0 meant that there was no reduction in uptake. The only thing which caused a reduction in the uptake was this vegetable called rutabaga. Okay, it's similar to turnip, but it's not turnip. And it's used mainly in northern European countries and in Canada. It's a very hard vegetable. It's a hard root vegetable. You generally cook it when you eat it. In that study, they gave it raw. Okay, it's also called a sweet for those of you who are interested. So what was the bottom line? Very recent survey. Do brassica vegetables actually affect thyroid function? They did a very detailed systematic review. And what they found was the vast majority of the studies were animal studies, very few human studies. Most of them actually studied broccoli. A few of them studied cabbage. There was one study with cauliflower showing absolutely no impact. So what is the bottom line? Brassica vegetables do not affect your thyroid function at all, okay? Unless you're going to eat raw rutabaga, which I think is, nobody can eat raw rutabaga, so I wouldn't worry about it. However, if you're still worried about, and if you're a person who's, say, eating, like you're on a low-carb diet, you're eating cauliflower rice every day or something, even then, if you want to reduce your goitrogenic substances, if you steam cabbage for 4 minutes, or if you stir-fry, these for a few minutes, you are going to reduce your goitrin levels. So microwaving also reduces the goitrin pro-goitrogenic levels, but it also probably causes a reduction in the other good things, the isothiocyanates. So probably boiling is the best way. The way we cook it in India, I think is okay. You add water, you cover it with a vessel most often when you're making your, poriyal and all that. So I think that's a good way to reduce the goitrogenic substances. So I hope, are all of you convinced that everybody can eat cabbage and cauliflower? Yeah? Thank you. Very good. Okay. Then this is a question that I'm asked sometimes. Okay, does eating cruciferous vegetables actually increase your cancer risk? I think it just keeps floating around occasionally in social media. And I think it was based on this one study from Poland, which was published about 10 years ago. What they did was they took about 300 people with thyroid cancer and compared them with about 600 people without thyroid cancer. And then they put up a graph like this. No numbers are mentioned, only a graph like this. I couldn't find any numbers. And what it showed was that more people in the thyroid cancer group reported average or frequent intake of cruciferous vegetables, that is this. But also, the people who had thyroid cancer, lesser number of people smoked and drank alcohol. So if you went by this study, okay, if you smoked, you drank alcohol and ate lots of, ate no cabbage at all, you could protect yourself from thyroid cancer. So just to say that this is not true at all, and other studies, a pooled analysis of case control studies have clearly shown that eating vegetables overall reduces your risk of multiple cancers. Cruciferous vegetables reduces your risk of, many cancers actually, because it contains those isothiocyanates, which are cancer protecting chemicals. So please don't not eat cabbage and cauliflower, and please, I don't want any doctor from here to, from now on, tell patients not to eat cabbage and cauliflower. So please don't, okay? Now, coming to the thyroid and the oxidative status. Like I said, the thyroid, in fact, uniquely among all endocrine glands, I would say, because of this constant generation of H2O2, is affected by the oxidative status. We all know how bad ROS, reactive oxygen species, are bad for us. We're talking about it in diabetes, we're talking about it with atherosclerosis. We know that when we eat too much, we're just generating too much of ROS, which is destroying us day in and day out. It particularly affects the thyroid. So studies have been done which show that people with Hashimoto's have an increased level of oxidative stress and damage. So can we reverse it? If you actually reverse the same diet that we're going to recommend to someone, let's say to lose weight or to have, if we want to reverse their diabetes, we're going to put them on, no sugar, low carb, high fiber, more protein, that type of a good diet and get them to lose weight. Is that also going to help with the thyroid? One analysis in Polish patients showed that people with Hashimoto's were consuming more protein, and they did not have enough fat, and they did not have enough fiber, and they had excessive consumption of easily digestible carbohydrate. And what they did was they put these women, 50 women in each group, all of them with a BMI of about 30, and suffering from obesity and Hashimoto's, actually they were hypothyroid, all of them were hypothyroid with positive antibodies. And what they did was the two groups, one was just a weight reducing diet. The other was a weight reducing plus an elimination diet. So for all of them, they did these studies. They measured the IgG levels about the food sensitivity. So you can see what was measured, were they allergic to wheat and egg white and cow's milk and yeast and corn and gluten. And the prevalence of these food insensitivities was equal in both the groups. And in one group, they did just a balanced reducing diet. So they just said eat less. In the other group, they said eat less, but also eliminate all the things that possibly your body is allergic to. And these were the results. You can see that in the group that was on caloric restriction with elimination, they lost more weight than the group that was on caloric restriction alone, 21 kilos versus 17. The BMI dropped 21%, 18%. In both the groups, the thyroid levels improved. I think any which way you lose weight, you're going to reduce your oxidation. You're going to reduce your ROS. You're going to, your thyroid levels are going to improve. I said when you lose weight, your TSH improves, and that improved. The TSH, which was slightly high, came down. The thyroid antibodies dropped by 72%. Dropped by 51%. So losing weight is helpful. Losing weight with elimination diets, if you're so inclined, doing all these, testing for various food intolerances may help in some situations. So yes, diet is important. What you need is a well-balanced diet, which lets you avoid weight gain. But there are no specific foods which harm or help the thyroid. And any diet which helps you reduce reactive oxygen species will help in the thyroid. Millets and thyroid, okay? How many of you think millets are bad for thyroid? Okay, thank you. Because I was going to say nobody is now going to lift their hands. So this was based on a study from Sudan, and I'll quote that study a bit later, where they showed that people in rural areas seem to have larger prevalences of goiter, and those people living in rural areas in West Sudan got most of their food intake from millets. So from that, they extrapolated This was one of the earliest studies. You can see that it came out in 1989. They took millet. And it was fascinating. They took one 8-kilogram sack. It went all the way from Dakar, Senegal to Jackson, Mississippi. Study was done in rats. They took these millets with a grain. They dehulled them. They dehusked them. And they got the bran fraction. And then they got the, the inside bit fraction. And the bran fraction with the highest level of this compound, glycosylflavone, this is what they studied in the rats. And the rats that received this bran fraction had an increase in their thyroid size. And at a concentration, they found that this bran fraction, so the outer covering of this pearl millet is bajra, by the way. So pearl millet, bajra, the outer covering bran contained high levels of this chemical, which interfered with thyroid function in rats and which was equivalent to methimazole. So I thought that was fascinating. But what about other millets? I mean, the millet that is most commonly used in our country is ragi. It's called finger millet. I didn't find any study about, human studies about it. I didn't find any animal studies also about it, except 1 or 2, but indirectly. So what they did is they took these millets and they looked at the presence of these compounds, these goitrogenic anti-TPO activity compounds, this vitexin and isovitexin compounds. And this study was there, again published a few years ago. And what in this study, interestingly, what they found was that these anti-thyroid compounds were found in something called kodo millet, but they were not found even in pearl millet. They were not found in bajra. They were not found in finger millet also. And of course, the previous speaker was talking about the necessity for systematic review. This came out very recently. Does consumption of pearl millet cause goiter? A systematic review of existing evidence. Totally only 9 studies are there. Out of those 9 studies, only 2 are in humans. This first study here is the one that I was quoting. The one which came out from Western Sudan, where goiter was more prevalent in rural areas, all of that. 8 of those 9 studies were done on pearl millet, 2 in humans, 6 in rats, and 1 on some other millet. But basically, bottom line is, absolutely no evidence. Please eat your millets, okay? No problem about eating millets and its effect on the thyroid function as part of a balanced diet. There may be something to do with the way we cook the millets. I'm not going into detail, but in general, the way we cook it, which is just maybe maximum fermenting it for like an hour or 2. In some of those African countries, apparently they ferment it for up to 2 weeks and they eat it. That's a different matter, but in our country, I don't think we ferment it for that long. I'm not sure. Okay. So I'll finish up the last few slides with gut health. Some of this has been alluded to. I don't know how many of you are aware of this study, the ICMR INDIAP study, which was published in the Lancet in July, I think in June, yeah, in the beginning of July, and which said that 250 million people in our country have dysglycemia. 100 million people have diabetes, 150 million people have pre-diabetes. So a quarter of our population, and it's got other, equally alarming numbers in it. One of the reasons, among the many reasons that have been quoted, one of the reasons I think is the changing microbiome. And I think one of the reasons for the changing microbiome is because we eat at different places constantly. Our food is not homogeneous. If you think about the main difference between us and our parents or our grandparents is, once a year they may have eaten outside, or twice a year they may have eaten outside. Every other day their food was very homogeneous, very, very thing. We keep eating out. We have, we have all these food delivery services and we keep eating out. Okay, so this is one of the reasons it affects our microbiome. The microbiome in our body, for those of you who are not familiar, I'm sure you must have heard lots of talks, consists of 6 main phyla with 500 to 1,000 species. Some are good and some are bad. I'm not going to go into detail, but they affect our gut health in various ways. They cause inflammation. They cause what is called a leaky gut. They are helpful in producing short-chain fatty acids. I'll talk about that a little bit. They also work on converting the primary bile acids, which come from the liver, into secondary bile acids, which works on improving the activity of the PPAR gamma. For those of you who are using pioglitazone, this may be familiar, PPAR gamma. So it improves insulin resistance, but it also works on the trimethylamine. Dr. Arun had referenced this in his talk. So it also works through this pathway and causes dysbiosis and increased insulin resistance. But I'll just talk briefly about short-chain fatty acids. Short-chain fatty acids are just basically fatty acids which contain 2 carbons or 3 carbons or 4 carbons. So just remember to think about the number of carbons. These are all made by the bacteria which are living in our gut. And these short-chain fatty acids working through the G protein coupled receptors activate the immune system, They work on the blood-brain barrier permeability. They work on the gene expression pathways. Very interestingly, they increase production of GLP-1. So GLP-1 helps to control your sugars. You must have attended enough diabetes talks to know that GLP-1 is necessary to control, to make your body make more insulin. It increases the mucin synthesis. The SCFAs increase mucin synthesis. It helps to maintain the integrity of our gut so that you don't get leaky gut, so that the bacteria don't get translocated. It increases the secretion of peptide YY and leptin so that you have more satiety. It improves the function of these policing immune cells, the macrophages, the dendritic T and B cells, so that our body don't get invaded by the bad Shigella and the enteropathogenic E. coli. Okay. When you are on a diet, which is the Western diet, the bacteria that make SCFAs come down. So SCFAs are good. So when you're on a Western diet where you have high sugar, high protein, high animal protein diets, the SCFAs come down. Whereas if you're on a Mediterranean diet, it increases the production of these SCFA bacteria and reduces the concentration of the maybe not so good bacteria. So it tilts the balance in a favorable way so that our insulin resistance improves. The microbiome also plays a very important role through various mechanisms in improving our gut health. I've been fascinated by this slide, and I'll just put this up here. This is a slide which compares the number of antibiotic prescriptions that people are given. I think it is in their lifetime. If not, I don't think it's in a year, in their lifetime, and their risk of diabetes. So you can see that anytime you have taken antibiotic 2 to 4 times, it increases your risk of diabetes 1.2. If you have taken antibiotics about 10 times, it increases your risk of diabetes 1.6. Now that we know about the microbiome, we know that every time we take antibiotics, we're going to affect our microbiome balance, and it increases our risk of diabetes. So we should try not to be using antibiotics. So finally, I think like Dr. Regina said, a balanced diet helps the thyroid, helps the diabetes, helps the world. And what I think are important is no sugar, no added sugar, less carbs, whatever carbs we eat, less processed, less calories, and whatever we eat, try to eat less often, let our gut recover between our meals, high fiber, moderate protein, and good amount of good fats. And I'll leave you with one thought, okay? Remember that any food that our body doesn't need at that point in time is junk for our body. It may be the healthiest food, but it's junk if our body doesn't need it at that point in time. Okay? Thank you very much.
I can't believe how many pearls of wisdom she managed to give us in that 20 minutes. Thank you, Doc. And now I know when my thyroid patient comes up and says, I'm gaining weight because of the thyroid, I know what answer to give. So thank you so much, Dr. Jayashree Gopal.